Lovely people. Hello, it's Thursday. You know what that means. It means I get to share the discussion stage with a CP Solver star. And even though this person was nominating somebody else for El Presidente today, which will be a private internal conversation, I will say that that is a lie because he, in fact, is has started from being a very enthusiastic VMR member to being the co-director of our internal operations, which means Youssef is in fact one of the two big bosses in CP Solvers. And I'm so excited to get to discuss with him today. I think we all try to make Yusuf blush, but fail miserably because of how humble he is. But I think very few people embody the word CP solvers as much as he does. And I think what's special about him is what you all see on the outside is his incredible teaching and medical knowledge. But I think makes Yusuf truly a CP solvers is that plus his community building skills. I really think he's singular in his ability to bring people together and connect the dots and bridge relationships. And so super excited for him to be co-discussing today. I will keep talking to also share some thanks to Gerardo and to Patricia who are doing the scribing and the teaching points. So thank you both so much. I'll hand the mic to Yusuf to say hello, and then we can co-introduce our guest presenter.
Thank you so much, Rabih, for the warm intro. It feels like yesterday when I joined the team, when I was like presented a case of nephrotic syndrome last minute when we used to start the session and solicit cases. And I was like, okay, I guess I'll do it. And I just like jumped to the next room. And I remember our last two discussions, one with like maybe a hepatic lesion and diarrhea, and the other one was like, I think it was dengue. So I'm really excited to co-discuss with you today.
The pleasure's all mine. Yes, syphilis is the masquerader of nephrotic syndrome. I'll never forget ever again. And it's the beginning of something new again today. We have our first time case presenter from Ethiopia. Lul, I will hand the mic to you to say hello. Tell us a little bit about yourself, please.
Well, my name is Leul, and I'm a medical doctor. I recently graduated internal medicine physician from Ethiopia. I am really excited to be here. I've been following you guys for a little bit now. Not exactly joining live, but at least watching you guys on YouTube. And I'm so interested to be a part of it and discuss a case today.
That is so kind of you. We really appreciate those kind words and are so excited that you're able to join us live. I think every single person on YouTube uh, except the people who tell me to stop talking for 5 minutes to welcome people. All of you, except those people, are so deeply invited and welcome to come hang out. If you don't like these 5 minute long intros, I don't think you'll enjoy the session. So, Lul, very happy that you're here. Tell us a little bit about yourself outside of medicine. What do you like to do?
Well, I have what do I like to do? I like to play traditional musical instruments, specifically masenko and bagana, which are very old instruments, and I try to do that a little bit. I'm also a big football fan. I know you guys call
Yeah.
it soccer out there.
No, I don't.
Oh yeah. Yeah, I
Do
like to
you
watch
Do you
matches.
have any of those instruments in your room? I'm just so curious to see what they look like.
Um, I really don't. Apparently, I'm not in my own place right now.
I see. No
I'm
problem.
visiting friends.
No
So,
problem.
but next time I'll make sure to keep to hang one
No.
of them.
Yeah, that would be awesome. My final question for you is which team or do you support any teams or do you watch casually? What is your favorite football league or team?
I follow the Premier League very
Yeah.
closely.
Yeah.
I'm an enthusiastic Bayern Munich supporter, and I'm
Ooh.
also a big fan of Pep Guardiola,
Oh my
the
gosh. Yeah.
manager.
I'm so glad Ravi isn't here. He's a Manchester United fan. He would be pretty
Oh,
devastated to hear that.
yeah, there's a big rivalry there.
Yes, indeed. All righty. Well, thank you so much for telling us a little bit about yourself. We hope to get to know you even better throughout this hour and hopefully even in the future. Um, Gerardo, feel free to share your screen, and Lul, we can jump in with your first aliquot. All right, Lul, my friend, take it away.
Okay, so the patient I'm presenting to you guys today is a 20-year-old male patient who presented to our emergency department with a complaint of headache and fever of 2 weeks duration. And I think I'll give you the first aliquot as well. Right?
Up to whatever you had planned is totally okay. Do you want to stop here, or do you want to give us more information? Whatever you prepare.
Oh, then let me give you a little bit of the history then.
Okay.
So he's a 20 years old male patient. He presented to our emergency department after he had experienced headache and fever of 2 weeks. The headache was global, it was persistent, severe, and it was aching in character. He also told us that the fever had been associated with chills, rigors. He also had sweating, loss of appetite, as well as muscle and joint aches. He endorsed pleuritic chest pain and a mild cough that is productive of whitish sputum, which, while at the time of presenting to our ED, had become occasionally blood tingled. He was seen at a nearby hospital. After he was investigated there, he was diagnosed with malaria. He was treated with coartem, which is a combination of artemether and lumefantrine, pure anti-malarial drug, a combination drug. And afterwards, he completed the treatment for 3 days and he had no improvement. So he was referred to our hospital. The patient lives in an area where malaria is endemic. And besides that, the review of systems is negative. Past medical history, he has been experiencing episodes of right ear discharging pus for the last 8 years. And he also had decreased hearing in the same ear. And he has been repeatedly treated for it at a nearby health center with eardrops. And it did not improve, and it's still there, even though it's not discharging pus at the moment. Social history, family history were unremarkable. He did not have any drug histories, and he did not have any known allergies. I think I'll stop there.
Oh my gosh, absolutely outstanding presentation, Lowell. I can see the really deep skill set you've built over your training. And I'm really curious, Yusuf, where is your head going with this information?
Yeah, thank you so much, Lul. Very fascinating start, and it sounds like we have a young gentleman who's coming with headache and fever for 2 weeks, and we also hear about an interesting background of potential like cough with bloody sputum and a history of malaria exposure. Initially, when I heard the fever and the headache, the question is, like, I have the flu right now. If I have a headache, do I need a lumbar puncture? It's like probably not. But in this case, we hear like maybe the focus is around the headache, and which makes me think, could this be something in the CNS? The background is very interesting. We hear about cough with bloody sputum, but I want to overlap cough with bloody sputum with the acuity of it. This is not like chronic cough with bloody sputum and a headache. This is like acute to subacute cough with bloody sputum and a headache, which changes the spectrum of disease. For example, if you're thinking of like histoplasmosis, it wouldn't present this acutely. But if you're thinking of like bacterial organisms, they are usually faster to present. Or if you think of TB, it usually presents to chronic, to subacute, unless it's tipping over. And then we also hear about the history of malaria. And malaria is actually, like Lolo mentioned, pretty common in Ethiopia. And like public health efforts have been trying to fight the malaria by putting like nets And however, this has selected for a specific mosquito that is actually thrives in areas even without bodies of water, and it also reproduces during the day and at night. And it has this has changed the spectrum of mosquitoes. The organism is called Stevensii, and they nickname it Steve. And Steve the mosquito has been evading the efforts of public health officials around the world and Ethiopia, because now it's harder because malaria is popping up in the city and not just in rural areas around water, which has been hard to combat. So besides that tangent, how do I think of malaria and a new fever and headache? Of course, the biggest thing to consider is malaria falciparum, which can involve the CNS. I'm also thinking of the treatments. I'm not sure if that would cover malaria falciparum. I think honestly, I would look it up. And then in terms of the ear discharge, I think that's pretty interesting. I'm not sure if it's related or not. Could the patient have an underlying immune deficiency, like an IgA immune deficiency or HIV? I think that's something I would want to know upfront. And that would help me stratify the patient into how quickly I want the imaging and lumbar puncture. And I think that's where I am.
Gosh, I didn't know you were best friends with Steve. Geez, like your intimate knowledge of malaria is unbelievable. I knew zero of that. That was really educational. Thank you so much. Yeah, I'm right there with you. I have nothing to add, but just to try to paint the big picture template here. And the big picture template is, of course, knowing where the syndrome is and how long it's been going on for. And where we have both neurological features and pulmonary features. And as you said, we'll have to figure out, does the disease live in both, or is the neurologic or even pulmonary features a radiation of the disease with it not actually being there? So that's the where. And the time course is really interesting because you could say it's 2 weeks, but then when you hear that the patient has subacute disease in his ear, even chronic disease in his ear, you wonder if this is a complication related to that true time course. So is the time course of the disease really 2 weeks, or is it 8 years with a complication? I think that's an open question. I think morbidity would have you make sure that that you consider the most shortest time course, because the shortest time course is often associated with the most morbid disease. So if you're making that 2x2 table, you're like long brain, and then how long, subacute or chronic. And I think whenever you have the word chronic inflammation, the only two diseases that are explanatory for chronic inflammation, really long-standing, are either immunodeficiencies or autoimmune diseases. And so I think you'd wonder, does this patient have a structural immunodeficiency in his ear? There's something wrong with his tympanic membrane structurally. Or is this a focal manifestation as a result of a systemic immunodeficiency with tropism for a specific area? So I think we now have all these boxes open. What is the time course? Where is the disease? And I think only with really clarifying, the only progress we can realistically make is to figure out where the disease is, and then try to see if how the disease starts to declare itself. If we ignore the ear, or if we start to say, okay, you've got a vasculitis on your UA and you've got chronic ear issues, is this not infectious? Or we get a CT and you see bronchiectasis and you're like, oh, okay, you don't just have immunodeficiency here, you have it in your chest, and that changes things dramatically. So yeah, you added a lot more detail to that 2x2 box, and we'll see what detail Lil has in store for us. Back to you, my friend.
So interesting to hear you guys discuss the case. I'm learning a lot. I will give you the physical examination next. So when we saw the patient looked acutely sick. His vital signs, his blood pressure was 170 over 72 by 72. He had a pulse rate of 119, respiratory rate was 32, and his temperature was 40.5 degrees Celsius. He was quite febrile, and he maintained his saturation on room air, hovering somewhere between 94 and 95%. His HANT exam was all okay, except for the right ear, which showed that he had a perforated tympanic membrane with discharge, and there was a bony prominence in the external ear canal. The lymphoglandular system, the chest, the CVS, the abdomen, as well as the musculoskeletal and the integumentary examinations were normal. They were unremarkable. The neurologic exam, he had a fluctuation in his level of consciousness. He was lethargic to start and then became alert with fluctuating levels like that. He was asking to leave the hospital, and besides that, motor, sensory, and coordination exam were all normal. One more thing is from the meningeal signs, nuchal rigidity was positive. I'll leave you guys with that.
Well, I just want to say before we hear poetry from Youssef, this is a very, very rich exam. I literally can see this patient with my own eyes, and the picture that you're painting of him also wanting to leave the hospital is absolutely fascinating and alarming, quite honestly. So thank you. Yeah, Youssef, where did your mind go with this?
Yeah, I think it's very interesting to see the right ear. And like I know like classically if somebody just tells you, hey, I have a patient coming in with possible meningitis, meningoencephalitis, that would be the center of focus. So I'm trying to think how the ear is related to this syndrome. And one option is the same immune deficiency that you mentioned predisposed this patient to both having an ear infection and the meningitis at the same time. The other option is he had a certain susceptibility, and maybe there's a complication of the inner ear infection. And for example, it's not hard to imagine a pseudomonal infection, a bacterial hyperacute infection that disseminates and causes like a meningitis or a pneumonia, for example. It's not particularly common, but it is definitely like plausible. And I have seen pseudomonal meningitis in the past, and I mentioned that because of the ear infection. I think also gram positive would definitely be at play. We're definitely headed towards empiric antibiotics, HIV, and an LP, and the order will be determined by how quickly we can get them. And the other thing I think not to miss here is lung imaging. And I think I would want like ideally like a CT scan, and also depending on the resources, because I'm not sure it would change the management right now, but it would may help us define the syndrome better. If for example we get like a scan there and we see like an infiltrate, we think, okay, this is more and more likely to be bacterial. If we see nodules, it might change our management. And like Rabih always tells us, like the most common source of the brain infections are in the lungs, but here we have another etiology, which is possibly the ear. So I think we're on a fast track towards LP antibiotics plus minus lung imaging, and initiating like an immune deficiency workup with at least an HIV plus minus immune globulin levels eventually.
I love that analysis. I completely agree with you. I think, in the past, Youssef, I probably misspoke about lung being the source, and I wish I had used the word respiratory tract because we had an instance, a really educational instance of somebody who had strep pneumootitis media who then developed meningitis. And it literally live on VMR, I wasn't the discussant, but I was listening. I was like, wow, the connection between the ear and the meninges is so interesting. Of course, as you just alluded to, you can have direct extension from the ear right into the meninges, and that can initially begin with mastoiditis. Then you can have a subdural empyema, and then a meningitis, and an intracranial abscess. So it can literally go right inside. It is interesting, though, to speculate on the sheer number of instances that meningitis is caused by respiratory flora, including strep pneumo and Haemophilus influenza type B. And we don't talk about those so much in many parts of the world because of the efficacy of vaccination against those two organisms. And so they slip our mind. But I think if you ask, the top 4 or 5 causes of meningitis without vaccinations globally, strep pneumo and H flu type B, both of which are residents in the upper respiratory tract, including the ear, are notorious for that. So it's interesting. I think the connection between ear and meningitis is, of course, a direct extension, which would be very plausible given the chronicity of pus formation in that ear, but also hematogenous dissemination. And so I would love to update because it's funny, both you and Austin yesterday quoted me on this bridge between lungs and meninges, and both times like, no, it's not the whole story. And that's because I learned that right here in VMR. So I tweak it to respiratory tract, including the upper respiratory tract. And so I think, the meningococcus or H flu are very, very plausible organisms here based on that mechanism. But I agree with you. I think that, we're on as you said, we're on the moving train, and I'm really curious because I think there's a little bit of practice variance. So say this patient is in your hands now. I'm really curious what your sequence of events would be like, because I think it's important to do many things, but I think also maybe the order of things might be something that people are interested in. So what would your next sort of sequential evaluation be?
Yeah, I think my order of events depends on how important it is for me to know the organism and how sick the patient is. And for example, if somebody is slightly encephalopathic, slightly febrile, I'm like, it's really important to know the organism because it might just be delirium. Let's say a 65-year-old, it might be delirium. And I would prioritize getting the LP first because it's very important to identify an etiology. But if somebody is like this person is young and they're highly febrile, and I have a very high pretest probability of having a bacterial suppurative meningitis, I think I would prioritize antibiotics and imaging first
Mhm.
because treating might be more important. And here we hear that the infection, there are two pathways. So it could be infection in the ear goes directly into the brain, or infection in the ear goes to the blood, and from the blood to the brain. But I think here we also need imaging because contiguous spread is an option
Exactly.
here. So I think we won't do an LP until we get imaging first. And I think here I would start with antibiotics/imaging and then LP, I think. But what would you do?
No, I completely agree with that. I think that, you ask yourself, this person as a 20-year-old, is no longer able to engage with the world. They've lost one of the three cardinal functions we try to protect: eat, walk, and talk. And he probably has lost all three. I can't imagine him eating. He's not talking, and I can't imagine him walking. 3 of 3 gone. Empiric antibiotic therapy. So you ask yourself, why the heck would you not give him antibiotics 5 minutes ago? And the only answer, I think, is to try to increase the yield of blood cultures. So the only thing that I would try to do is to, in 2 seconds, get an IV and get blood cultures, and then give him antibiotics right away. Um, and I think that's influenced by the fact that the probability of an intracranial process is so high in somebody who's young and otherwise healthy. And the consequences of empiric antibiotic therapy are nothing beyond reducing the culture yield, which in this situation where all three cardinal functions, eat, walk, and talk, are gone. So I think blood cultures, antibiotics. And then the question always is, do you LP before you CT or do you CT before you LP? And I think, given that we're already at the half minute, 30-minute mark, I don't know if we have time to explain that, but I think what you said is so wise. This person has a decent probability of having focal intracranial disease by the mechanism we're invoking, potentially, that he has contiguous spread from his ear. And so the reason to get imaging before LP is twofold. There's the hypothetical risk of intracranial herniation if you put a needle in somebody who already has intracranial pressure, that they might herniate. But also, realistically speaking, if you see an extra meningeal focus of inflammation, see you see a subdural empyema or you see an intracranial abscess, the microbiological yield of your lumbar puncture drops significantly. That's because if you see that the patient has a non-meningeal focus of inflammation like an abscess, the yield microbiologically of a lumbar puncture is low. And so you might then just recognize that the CSF may tell you there's a little bit of inflammation, but you might not invest in those cultures significantly. So the CT, if clear, probably tells you the lumbar puncture is going to grow the organism. If CT shows an intracranial abscess, then the probability that there's actually meningeal involvement is lowered. So that's probably how I would go about it. But we're assuming that there are all these resources and whatnot. Who knows? Who knows what tools we have in our back pocket?
Yeah. And the other thing I thought of, Rabih, is also like steroids. I think we don't see meningitis enough, but steroids have like a significant benefit, especially with like strep meningitis, and here it's also high on our differential. So I think people are scared to give steroids in these scenarios, but the experts do recommend giving steroids specifically because it has like a significant benefit in strep pneumo, potentially in Haemophilus.
Anyone who knows Steve is an expert by definition, so I'm right there with you, my friend. I'm on board. All right, Lil, what you got next?
Yeah, so good to hear you guys talking about this. Like I said, so we were thinking just like you guys talked about. So since he had a change in his mental status, we wanted to image him first. So let me give you the first uh, investigation aliquot. So the WBC count it measured about 4,000 with neutrophil of 81%. He had a hemoglobin of 16.7. Platelets were 51,000. ESR was done. It was 70. His creatinine was 0.6, 0.6. The liver enzymes were all within the normal limits, as was the urea. The urine analysis was also unremarkable. Hepatitis B surface antigen, hepatitis C antibody, as well as HIV testing were done. All came back negative and non-reactive. Blood cultures were taken. We did a brain MRI and we saw it and it looked grossly okay. So LP was done and we waited for the formal read to come back. In the meantime, we also did repeat TIC and TIN smears for hemoparasites, and it showed that the patient was positive for Plasmodium vivax. So at this time, at this juncture, our considerations were like you guys were thinking about pyogenic meningitis. The patient was also delirious as well as having malaria, it being probably severe as well as cerebral malaria in our consideration. So he was started on artesunate, and we also started him on broad spec antibiotics with vancomycin and ceftazidime. And I'll let you guys off here, and I'll tell you what happened on the next aliquot.
Wow, fascinating. Yeah, Yusuf, what are you thinking?
Yeah, thank you so much, Lo. To start off, we see here we have like an elevated hemoglobin and some thrombocytopenia, and it can be it's very tricky to see this combination together, because if you see it automatically, you might say, oh, this is a viral syndrome that has both, or this is like a tick-borne illness because you have thrombocytopenia with meningitis. And I think that's a good thing to keep in the back of your mind, in your back pocket, of low threshold to start like a doxycycline, for example. But we have to not forget that suppurative infections typically can also cause DIC-like picture, and the most sensitive marker for DIC is thrombocytopenia, and usually it's the first sign to present. We don't see any other signs of it though so far. So that's regarding the platelets. I don't think I would necessarily start any like doxycycline at this point, but I would like wait for the cultures first, just because of the acuity and how fast it is, and usually it's also geographic. So I would see how endemic those organisms are. The other thing is like dengue fever for sure, and other viral etiologies, and most of these you would send the workup, but it doesn't necessarily going to change your management on day one. So you don't necessarily have to change anything in your management. You just start sending viral serologies or antibodies, which are common in Ethiopia as well. And then in terms of the malaria, we see here the vivax organism, but I think could there be like a sneaky falciparum? I'm not sure. The MRI is reassuring that we don't see any signs on MRI, but I think I'm not sure if we would need to like repeat it, or how we would detect like the sensitivity of a smear for detecting like falciparum. I'm not sure. I would ask the experts, to be honest.
Yeah, and that's such a great analysis of the CBC and the clinical syndrome. And I think the tension here with the malaria, Yusuf, is the base rate of disease. And I think if you live in an endemic area, the probability that you have some parasitemia without symptoms is so high. And so I think that it goes to show you that unlike travelers who go to malaria endemic areas, if you find malaria in the blood, you know that there's very likely causative. But in hyperendemic areas where patients are chronically infected and symptoms develop as a result of essentially a fight between the immune system and malaria. I think here the reason to doubt or to cast the only license you have to cast doubt on the acute significance of this finding of malaria is one, that patients who are endemic in the region are expected to have some degree of parasitemia as a result of existence in that area, and then the weaker association between non-falciparum malaria and cerebral malaria. So not only could this finding be chronic and unrelated, it also could be hypothetically less married with a cerebral presentation. Of course, the patient's too ill to make those assumptions, but I think you have to understand that that's a possibility and make sure you cover your bases elsewhere. And I think when you look at that CBC, you realize that this is a fingerprint of a disease that we maybe weren't expecting, because I think if we were invoking pyogenic bacterial meningitis, you might expect a leukocytosis and a thrombocytosis. And so here we're getting the exact opposite, a picture very, very evocative of arbo-borne infections, ticket-borne infections, or mosquito-borne infections. And so I think that, yeah, that's for me, the CBC really, really caught my eye because it made me want an HIV test even more given the leukopenia. And given the thrombocytopenia, I've become more worried about an exogenous organism, an organism coming from outside the body, which may be malaria, of course, but we talked about why there's reasons to doubt that. So you ask yourself, like, what kind of non-malaria organism causes thrombocytopenia? And I think there's a whole range of viral infections, bacterial infections, and other parasites not relevant in Ethiopia, like Babesia. But long story short, I think now you're like, whenever, I'll give you a quick rule of thumb, whenever you have infection plus thrombocytopenia, worry about the organism coming from outside of the body. And I think that's a really, really important reflection to emphasize. The other big thing that really might catch your eye is to see somebody this sick for so long, for 2 weeks, to have a high hemoglobin. And that high hemoglobin invokes the idea of possibly a vascular leak phenomenon, of which dengue would be the most notorious worldwide. But I know that in some parts of the world, there are viral hemorrhagic fevers that extend beyond dengue. So I would probably have to look up in Lowell's region, what are the viral hemorrhagic fevers present in that area. But I do think that the next step is, of course, to do a lumbar puncture. And the question is, how does the MRI being unremarkable initially as a wet read influence that calculus? And I would say that chronic meningitis shows up on an MRI. Acute meningitis may not, especially if the patient wasn't given contrast. But if you had to bet on what kinds of organisms cause a completely unremarkable MRI and cause CNS devastation, it's often viral meningoencephalitis. So yeah, I'm very, very intrigued by the CBC. I think it offers a twist that I wasn't quite anticipating. All right, Lowell. Wow.
Okay.
What do you have next?
So you guys asked about some of the viral hemorrhagic fevers. So we tend to have dengue fever as well as chikungunya in our country. Of course, they are not very common at the place where I saw this patient. So they are more common in the eastern part. So I was looking at treating this patient while we were in southern parts in a city called Hawassa. So that's why we didn't think of them as highly while we were treating him. But I'll give you the next aliquot. So the LP showed that there were no cells. The other parameters of the LP were also normal. The blood cultures did not show any growths. Unfortunately, only aerobic cultures are done in our facility, so anaerobic cultures were not done. Chest X-ray showed that the patient had features of atypical pneumonia. We also did a sputum gene expert because tuberculosis is very common where we practice, and the gene expert was negative, as was the sputum AFP. And the brain MRI read came back, and it showed that the patient had right middle ear and mastoid air cell T2 hyperintensity, having patchy contrast enhancement. And it also had a smooth leptomeningeal enhancement, more over the right inferior temporal occipital area. There were no mass lesions, no air fluid level seen, and their conclusion was that the patient had right ear otomastoiditis, which was complicated by an adjacent meningitis because of the smooth leptomeningeal enhancement on the adjacent area. So with that, I also should tell you how the patient was progressing. And the patient, this happened on the fourth day of his admission, and he was no longer delirious after the antibiotics were started. But despite that, and despite the antibiotics as well as the antimalarials, his other symptoms persisted. He continued to have very high fevers, reaching 39 to 40 degrees most of the day. He was still tachycardic, he was still tachypnic, and his chest this time showed that he, on physical exam, had coarse cryptations over the posterior right lower lung fields. So we decided that the antibiotics were not covering whatever we were trying to treat, and decided to change them. And this time we kept the vancomycin, but we decided to add metronidazole because of the possibility of autogenic still infection, and we added cefepime, and we saw the patient and how he continued to progress. Let me stop there, and I'll give you one more aliquot next time.
Oh, wow. You have us on the edge of our seats. May I just ask you one question before we hear Youssef's reflection? Can you remind us of the initial antibiotic choices? What were the initial antibiotics given before you broadened?
Oh, he was started on vancomycin and ceftazidime. So he took them for 3 days, and we decided to revise it to vancomycin and cefepime and add anaerobic coverage. And even though there were no cells in the LP, we decided that we are going to repeat the cultures and the LP and all that.
Super helpful. Thank you so much. So, Youssef, what are you thinking now?
Wow, what a case, first of all. Thank you so much for presenting. It's really fascinating. We have a young patient who's presenting with like a meningitis-like picture, and we have a leptomeningeal disease on imaging who has not gotten better on antibiotics, and seems to have like a pulmonary fingerprint as well. And I do like to use the schema, the CP schema, wrong bug, wrong drug, source control. And we can go through these one by one. So wrong bug, like Lul alluded to, could we wrong bug, wrong drug go together here? Because could the antibiotics we're giving not covering appropriately the organism? And ceftazidime has a little bit of gram-positive, negative, and pseudomonal coverage, and does have good CNS penetration, and is oftentimes like the first-line therapy for if you suspect pseudomonal meningitis. What was the other one other than the ceftazidime? Sorry, Lul. Vancomycin. And vancomycin is primarily for MRSA. And so I think that's the first option. The other option is source control. So like Rabih mentioned, could there be like a leptomeningeal focus without that needs drainage, for example, or needs a surgery? It doesn't sound like it here. And then in terms of what organisms we could be missing, so anaerobic organisms is a good one. I see like David mentioned like nocardia. I think that's a good option. For example, it definitely can present this quickly and can cause actually chronic infections, chronic nocardia infections. And the other one is on the top of my mind that causes sulfur granules, also causes chronic suppurative infections in the ear and in the lungs as well. So I think these two are definitely at play here. And I think changing the antibiotics is definitely the right option here. And the question is what to do next. I think trying to get an organism either from lung cultures, respiratory cultures, or to see if we can get like a bone biopsy from the middle ear. I think that might be hard. So I think I'll be speaking to the surgeons, potentially starting coverage for the organisms that we're considering that can cause chronic suppurative like ear infections like nocardia or actinomyces is a good idea here, I think.
Yeah, Yusuf, I think you're using the antibiotic failure schema here is absolutely superb, and I think there's certainly no doubt about that. And I think the question that I'm wondering is, do we really need, we take acute, we take acute fever, and we think infection, and do we need to move beyond infection right now? I think the answer is no, because the patient is too ill for us to entertain anything else, and there's been no overt stigmata of any non-infectious considerations. And so I think that's the first pass. And the second pass is to wonder, well, where is this infectious process and where could it be? And I think we have a hint that it might be in the brain, but not necessarily in the meninges, because not necessarily in the on the inside of the meninges. And I say that because we see evidence in infection in the right, or inflammation in the right ear, extending into the leptomeninges, but clearly that it hasn't made it to the other side given the lack of inflammation on the LP. What I'm wondering is that MRI finding a marker of the disease right now, or is it just a marker of the chronicity of the disease process and what's been happening to him for quite some time? And that's an interesting series of hypotheses, because we're now getting more and more momentum that the disease lives in the chest. And by virtue of the patient having hemoptysis, having a pleuritic chest pain, and now decompensating from a respiratory perspective, while he seems to have woken up from a neurological perspective and is less delirious. And so I'm right there with you, asking myself, well, why would somebody with a vulnerability in his upper airway get a serious and sinister lower airway process? And I think the organisms that you outlined are very, very powerful, as a very powerful checklist. I think the hypothesis of thrombocytopenia, implying the presence of an exogenous organism, is now being called into question by the fact that the patient seems to have a pyogenic focus in one side of his lung. And in most instances, exogenous organisms tend to be a little bit more symmetrically distributed. And I use that as a reminder to think about some of the endogenous causes where a patient with thrombocytopenia might have an endogenous infection. And of course, the easiest answer is severe sepsis, where your platelets plummet. But also, it's actually found in the vast majority of patients with Fusobacterium infections. And so I say that because this patient is super, super sick. And when I ask myself what kind of upper respiratory organisms make people very sick, so hectically so, nocardia is possible, actinomyces is possible, but the two organisms that cross my mind are the Strep milleri group and Fusobacterium. And I think Fusobacterium deserves specific mention here for two reasons. The first is we didn't have good anaerobic coverage before. Now we do. Ceftazidime and vancomycin leave a decent anaerobic hole, which is plugged by the metronidazole. And we heard earlier from Lowell that the ability to grow anaerobic cultures on blood is not something that is default in their facility. And it goes to show you how some anaerobes, like Fusobacterium, which is a facultative anaerobe, may sneak behind you. So I think that the hectic nature of this is infectious. I think that the lower respiratory tract is blossoming. And when you have a young, healthy person who has a blossoming lower respiratory tract process that is evading vancomycin and ceftazidime, I think you might have to wonder, wait, is it an anaerobic organism? But I think the next steps would be to really understand what you said from the get-go. Can we get more clarification on what this respiratory element looks like with the repeat chest X-ray, a point of care ultrasound, a CT scan? I think that'll be very, very illuminating. So Lowell, why don't we hear your final aliquot before the diagnosis, and we'll try to make some progress.
I must say we really would have benefited had we had you guys discussing this case with us. We would have really benefited from your thought processes while we were treating this patient, because we found it a little bit difficult. So we did the things that you just mentioned. So we repeated the LP just to be sure, and the repeat LP again showed that there were no cells, and I mean by no cells, I mean no WBCs, and the other parameters were also okay. Blood cultures were repeated and they did not show any growth. So the repeat blood film was also done, and after the patient had received artesunate. So this time it was negative for hemoparasites. So we had treated the malaria. We also did a peripheral smear, and it showed that the patient had many toxic granulated neutrophils. The RBCs were normal in terms of their morphology. There were aggregated platelets, which implied that they were falsely low. So we also did ANAs, we did rheumatoid factor, both of them were non-reactive. An abdominal ultrasound was done and it showed that the patient had hepatosplenomegaly, and there was a right side mid-lung zone posterior aspect hepatization consolidation. And as you guys said, we wanted to know more about the lung involvement, and we did a chest CT, and we saw that there were multiple randomly distributed bilateral lung nodules, consolidations, I should say. Let me rephrase that. Bilateral lung rounded consolidations, which were associated with a peripheral ground glass attenuation, and some of them had cavitation as well as a feeding basal sign. There was minimal left side pleural cavity collection with adjacent lung collapse consolidation. And we thought that this was highly suggestive of an embolic phenomena. And we wanted to know where it was coming from. So we started workup for sources of septic pulmonary emboli. And in the meantime, we also did an echo, which was normal. Third blood culture was sent and it was negative. And the patient developed neck swelling as well as tenderness and right arm swelling. So this is what we found, and I will reveal the diagnosis on the next dialogue.
I just want to address something you said, Lowell, which is that that you would have benefited from our thinking. I think the answer is probably not, to be honest with you. I think that um, the resources you have at your disposal are awesome. You're delivering, I think, the kind of quality of care that many patients in the United States probably wouldn't receive. To have a brain MRI on admission, almost unheard of in many parts here. So that aspect too. But also, you know, the truth is, this is why we ask people to present their cases as a route to being part of the CP Solvers Academy, is because it allows us to see both your passion for medicine, which yours is through the roof, but also your command and understanding of it. And the ability to tell the story that you're telling is largely dependent on how well you know the disease you're telling the story of. And so I think the fact that you are making progress towards this entity in a hectic, sick situation is very remarkable. It's very easy to sit here, sip coffee, and pontificate. So I think the patient was best served by having you there and your team there, and I think we probably would have been honored to be there with you, but not much else, to be honest. Um, so Youssef and Steve, what are you guys thinking?
Fascinating case, though. This is the twist and turn at every aliquot. So thank you so much. We hear here that we have a patient with multiple like lung nodules and lung infiltrate, and we see some arm swelling. And like Lul mentioned, could this infection be in a central location like the heart? Like, could this be an endocarditis? The caveat being is that we already have broad coverage, and this typically affects most bacterial organisms that typically cause an acute endocarditis. The other thing we have to consider is that other than the heart, could this be in the blood? Like Ravi mentioned, could this be a organism in the blood that's thrombogenic, that causes that can spread from location to location because of we're not covering it initially? There's that option. And then should we consider non-bacterial organisms like fungal organisms? Like if this patient was on chemotherapy or had neutropenia, this would be an automatically started on coverage for invasive aspergillosis, like immediately because of the susceptibility. But here we don't hear a susceptibility so far, but it does fit the picture for like an acute invasive aspergillosis if this patient was neutropenic. But we don't hear that so far. But if he decompensates, that's something I'm keeping in the back of my mind. If we don't isolate anything on cultures, and we want to make sure he doesn't decompensate. And Fusobacterium, like you mentioned, is on the differential. We already started the coverage. The only question is, do we need drainage of any site? Is there like a pericardial effusion and empyema that needs to be drained? And then, is there anything we're missing? I think that's a hard question. Like other organisms, for example, that are subacute to chronic, like Brucella, does not typically present this acutely. All the causes of lung nodules are classically chronic to subacute, but we have a very acute presentation. So it's not high on my differential list. So things I would do is I think look for anything to drain, continue the anaerobic coverage, follow the cultures. Considering of endocarditis, I think that's definitely like a good idea. Like if the patient's not getting better, we would definitely go down that pathway of getting like an echo plus minus TE if that's the consideration, especially if we see like septic emboli in other locations. And then Fusobacterium can also cause like osteomyelitis of like bone, and a lot of times these events need debridement. So you need to image the upper extremity, the lung, the chest, because it can cause like a gas-producing osteomyelitis as well. What do you think, Rabih? It's a hard case.
I think it's a very, very difficult case, Yusuf. Absolutely incredible. And I think the journey that we're on is unreal. And what I'm doing now, honestly, is I'm landing where you are, but I'm reminding myself of the journey of this person who has a vulnerability here for a long time, who comes in and is septic, super high fever, confused, and has the pathognomonic signature of a pyogenic bacterial infection, which with toxic granulations of his neutrophils. So here you are, and you're saying, I have really I don't want to say definitive, but near definitive feature of pyogenic bacteria, which they make your neutrophils very toxic. And then you have a little bit of a clash, because we all know, Youssef, that when you have pyogenic bacterial infections, they don't last for 2 weeks. So then you start to contort that, and you're like, oh, okay, this must be a hidden abscess-forming pyogenic bacterial infection. It's the only way you can get a pyogenic bacterial infection for 2 weeks, really. And so most of the time, when we think a bacterial infection in an abscess, we make the assumption that it's extravascular in an organ. Lung abscess, kidney abscess, skin abscess. It's very rare for an abscess to be inside the blood vessels, an endovascular infection. Endovascular infection is very different than bacteremia. Endovascular infection means that there is not just freely moving bacteria. It means there's a pocket of pus, often on the heart valves, but can be anywhere inside the blood vessels. And the only reason we have to entertain that here is because we see the signature of that endovascular infection in the lungs. And now here's another paradox. How can you have an endovascular infection with negative blood cultures? We're saying that there's enough pus to occlude the distal pulmonary tree, but not enough to show up on a blood culture? That narrative is, so that here's the paradox. Pyogenic bacterial infection plus 2 weeks equals pus under pressure. Where? Usually outside blood vessels, but CT scan is telling you it's inside the blood vessels. Here's the other paradox. A pyogenic infection inside blood vessels with negative cultures You have to doubt your cultures. There's no way the cultures are doing what they're supposed to do. Because if the pus is blocking your pulmonary circulation, the microbiology lab should be able to pick it up. So then you have to ask yourself, what is the hole in my blood cultures? What are they missing? And what are they missing that can form abscesses? And I think that's when you just go anaerobes, 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 anaerobes. The yield for blood cultures for anaerobes, even with anaerobic bottles, is no more than 50, 60%. In fact, we know anaerobes are so hard to culture, we empirically treat for them in many situations, like in empyema, where you have to cover anaerobes even if you don't find them. And so then when you layer on to this case that this person has neck swelling and arm swelling, you've probably found where the endovascular focus of infection is. It's probably in the veins that are blocking those things. So for me, I would be very, very worried about an anaerobic endovascular infection. And I think the most well-described form is Fusobacterium, and the patient fits that demographic perfectly. He has a chronic upper respiratory vulnerability and has a very severe septic syndrome as a result. So what would I do with this information? I think that I would pour as much metronidazole, or maybe switch to ampicillin sulbactam in him. And I think the prognosis is very guarded, and you have to be very worried about this patient. So that would be I think the paradoxes are ironically, the points of resistance are the most productive ones here. Pyogenic bacterial infection plus 2 weeks, endovascular infection plus negative culture. And I think it's those very tortuous filters that I think evoke a syndrome that unfortunately is well described in young people like him. So that would be how I would think about it in real life. I'd be pretty worried about it, to be honest with you, and try to culture the organism with anaerobic bottles if we can, but honestly, empirically treat for it and see if we need to do anticoagulation. But I think the next step is a ultrasound of the arm and the neck to see if that suspicion that there's pus there bears fruit. I'm out of breath, Youssef. Maybe I have the flu too. Let's hear what Lowell has to say, then we'll get your reflection.
Yeah, so you guys were quite on point. And so what we did finally was, as you said, we did an ultrasound. So we did an ultrasound of the upper extremity, specifically the veins, and we saw that he had extensive thrombosis of the internal jugular vein as well as the subclavian and axillary veins. There was surroundings of tissue edema, which was consistent with inflammatory changes, and there were multiple enlarged lymph nodes along with them, which were commented as being likely reactive. And we actually made the diagnosis separately. So part of the managing team was looking at him and doing the ultrasound, while me and some of the other members of the team, we were looking at the chest CT. So I talked to one of my radiology friends, and he saw the CT and he picked up something interesting. So he saw that there was a foci of air along the internal jugular vein as well as the subclavian vein. So that is when we thought about anaerobic infections as well as there being a thrombus. So the initial CT was not done with contrast, so we could not be sure about there being a thrombus at all, but the foci of air were very suggestive. And so we did a chest CT with contrast, and it showed us that there was thrombosis along the lines of those vessels that we just talked about. So finally, we did a temporal CT, and we tried to visualize the ear and rule out cholesteatoma, which we did. An anaerobic culture we could not perform, unfortunately. And our final diagnosis is, as you guys mentioned, you got it on point. So it was chronic suppurative otitis media, which was complicated with autogenic Lemierre syndrome and septic pulmonary thromboemboli. So I think I should also tell you how the patient progressed. So he was treated, we continued the IV antibiotics. He already has some improvement with the metronidazole being added, and we also started him on warfarin. As the thrombosis was quite extensive, we decided to anticoagulate him, and we put him on warfarin, which we escalated to 7.5 milligrams, and we achieved the INR target. He started to show significant improvement over the next few days, and by a week's time, the patient was no longer febrile, the cough and the hemoptysis had resolved, and the swelling of the neck and the arms gradually improved and disappeared. His labs also normalized, the WBC, everything else normalized. We also prescribed him ciprofloxacin eardrop to dry the ear, and we consulted our ENT colleagues, and they are waiting to do surgery and explore the mastoid as well as fix the temporate, what do you call it, the perforated tympanic membrane. And we also plan to give him primaquine as an outpatient to eradicate hypnozoids of P. vivax. So that's basically it. And I must say, I quite enjoyed your discussions, everyone.
Not as much as we enjoyed your case, my friend. I have to tell you, I will read Andrew's text to you. This was one of the best presentations of VMR. Kudos to you for presenting as you did. I think that couldn't be more true. The only way you can make my day better is if you join us live regularly. It would be an honor to keep learning from you. That was absolutely outstanding. But I talked
The
so much.
honor is all mine, right? All mine.
Youssef, thoughts?
Yeah, I echo what Robbie said. Fascinating case, Lul, and really like made us think a lot. And like at every aliquot, we were going in a different direction. It was very, very interesting how it came out. And now, like in retrospect, with the as Andrew says, with the retroscope, you can take a look and say, oh, maybe the platelets were being consumed because of the thromboses. Maybe the infection went directly down into the pharyngeal space and it went down into the lungs. And of course, like the third pathway of how like the lungs and the ear are connected is not just the blood, but it's also via like direct extension, which is pretty cool. And yeah, so fascinating case, Leo. And the other thing is we really want you to join, like keep joining and present even non-rare syndromes. So you're welcome to present just like a community-acquired pneumonia due to strep or no organism as are most pneumonias. That would also be amazing.
Well, I look forward to it.
Yeah, Lil, I want to echo that. I think that, you're yeah, I think we were all primed. I think when you said that you're presenting a case from not even your home city, we're all ready for some uncommon diagnosis, but this is a diagnosis that everybody can see anywhere. And so I think that it goes to show that while we tend to think that our worlds are very disconnected and that we have different issues in different places, I think most of the time we're all taking care of the same problems. And I think here you are illustrating that so well. So thank you. I really, really appreciate it. I can't thank you enough. But I'm very, very excited for Patricia's learning points. I'll hand the mic to you, Patricia.
Hello everyone. Thank you so much, Leo, for this great presentation. Like we learned a lot. Thank you, Youssef and Rabih, for the discussion. What I tried to gather from your amazing talk was we first started by approaching the problem from where and the time course, and the where we were in the CNS and the respiratory tract, like since we have hemoptysis symptom and chest pain. From the time course, we were more like we were thinking more about subacute or chronic process. And in the chronic process bucket, we need to think about autoimmune or immunodeficiency condition. From Youssef, we learned that if we have like an acute cough and headache, we need to think more about bacterial infection. In this case, we started focusing our thinking from ear plus CNS infection. So it can be from autoimmune diseases or complicated infection from Pseudomonas that can disseminate in the blood and go to the CNS. And we learned that the top causes of bacteria that can cause meningitis without vaccination are from the respiratory tract, like strep pneumo, H. flu type B, and they can spread through contiguous or hematologic pathway. We talk about management, especially in this case where we have like loss of cardinal function like eat, walk, and talk. And we decided to first do like blood culture, antibiotics, do a CT, lumbar puncture, and give some steroid. We discussed the lab. We discussed about lab like high hemoglobin and low platelet. It can be caused by virus like dengue or tick-borne illness. Infection with low platelet, we need to think about infection outside from the body, like with like fusobacterium infection. High hemoglobin can be take like vascular phenomenon caused by viruses like dengue or hemorrhagic fever. And it's important to know that in highly endemic area, people are expected to have some parasitemia in the blood without having the disease. We learned that chronic meningitis can show on the MRI, acute meningitis do not show, and viral infection can have clear imaging. So in this case, we were more like the were located inside the leptomeningeals and the pulmonary tract. Again, we we had that phrases wrong blood, wrong drugs, and we have a little talk about coverage with antibiotics like ceftazidime, which cover G positive. We had G grams positive coverage and a good CNS coverage too. Vancomycin that cover MRSA. Here we have like chronic suppurative ear infection can be caused by nocardia or actinomycete. Bacterial infection and abscess, usually we think about an extravascular process, but it can also be caused by endovascular infection and not just not just freely moving bacteria, but also a pocket of pus that should grow on blood culture. And so in this case, yeah, we were like, we didn't, we were surprised that we have like an endovascular infection, but we did not see anything on the blood culture, and we have a pyogenic infection that just lasts 2 weeks. So it was a great talk about like about antibiotics and some microbiology too. So we learned a lot. Thank you so much for the time and for this discussion.
If you all think that teaching a complicated case is hard, I think it's so much harder to try to capture that teaching and tell a story. And I think you did an outstanding job of that, Patricia. What an incredible hour to share the stage with you, Youssef, to have the honor of discussing your case, Lul, and to have Gerardo and Shema crushing the scribing. And a masterful job by Parisa. Thank you all so much. I hope you have a really amazing day. And I love the coincidence, the first name Youssef and the last name Youssef combining forces for an awesome session. Have a great day, guys.